Good morning, everyone. This is Steve Adelsheim. I'm hoping you can hear me. I am honored to be facilitating our discussion today, and I'm very excited that we have two wonderful presenters and experts speaking to us about community education strategies. I want to do quick introductions of each of them. Our first speaker will be Bill McFarland, a professor of psychiatry at Tufts University School of Medicine, former chair of the Department of Psychiatry, and director of the Center for Psychiatric Research at Maine Medical Center. Dr. McFarland has an extensive background, but really is someone I have been honored to know and learn from for many years because of his expertise in developing programs for people at clinical high risk for psychosis. Bill developed and ran the peer program and still is involved with the peer program out of Portland, Maine. The program really focused on building out programs for young people at clinical risk for early psychosis, and as a result, in developing the Peer Training Institute, continues to provide and support training all over the United States for people in understanding how to work with people within clinical high-risk related kinds of areas. Bill's peer program was ultimately replicated through the EDIPPP study with the Robert Wood Johnson Foundation, and I was honored to be able to ultimately be a collaborator at one of those sites, and it was an incredible learning experience for me as well. In addition, we are going to be hearing from Rebecca Janes, who is a licensed clinical professional counselor who's been with the peer program since 2007, both as a clinician and an outreach coordinator. Ms. Janes also works with the Peer Training Institute and has since 2010, and presented quite a bit on this areas around CBT for psychosis, multifamily group education, outreach coordination, recovery-based programs. Ms. Janes received her BA from Boston University in psychology and has a master's degree from University of Colorado, Denver. I'm really honored that we have these two wonderful speakers today, and their bios are actually on here as well under the speaker bio piece under the files, as well as their presentation under the community education webinar piece, and then they will be speaking later about the community outreach guidance manual through SAMHSA that they developed in more detail down the road. So Dr. McFarland, thank you very much.
All right, hello. Can you hear me? I guess
yes.
Yes, great. So our topic today is what we think of as probably the most important topic under the rubric of trying to prevent the onset of psychotic disorders. You'll hopefully by the end understand why I might say that, because I think for a lot of folks that wouldn't make intuitive sense, but we'll probably, I hope, clarify why that's true. So our topic, as the title says, is how to go about educating the communities that you're working in to identify people who are at least having a first episode as early as possible, and hopefully, and our focus really is going to be more focused on how to find young people who are at risk, who are having early signs of psychosis but are not meeting ordinary criteria for a psychotic episode. So we thought we'd do a few things today, some of them rather briefly. I'll go over some of the history of how we got to this place, not just in Portland, but actually the whole globe at this point. We'll talk about what happens when you successfully identify young people at the early stages of their onset, a little bit about current research, and we're going to focus a bit on the study that Steve has already alluded to, and that is the early detection and intervention for the prevention of psychosis study, which we were privileged to lead. Then we'll talk a little bit about the differences between First Episode and this what we used to call, and I still call, a prodromal phase. But mostly our focus, and Rebecca is going to do most of this, is how to do community outreach. What's the role of a clinic with a specialty team in doing this kind of work? So a little bit of history. This all really started with Dr. Ian Falloon in the UK. I'll say a bit about what he did in a minute. But almost immediately after his experience, a program evolved in the northwest corner of Melbourne, Australia, which has served to be a model for our work and many people around the globe. At first, the work focused on reducing what we call the duration of untreated psychosis. That is, trying to find young people who were psychotic, but as early as possible in their onset. The sad truth is, it's a couple of years usually before people get identified. So the focus has been on trying to reduce that by identifying people earlier. So the second phase of that was pioneered by Falloon with the simplest possible sort of community outreach and education method. He was working in a National Health Service clinic in Buckingham in England, and essentially just went down the hall in this multi-specialty practice and educated mostly the family doctors and the pediatricians in what to look for when somebody was having an onset. And 4 or 5 years later, they found that just with that simple intervention and Falloon treating the people that they identified, that the incidence of schizophrenia in that area plummeted to by almost 90%. So it looked like it would be possible to do what's happened in cancer and heart disease, and that is advance outcomes and reduce the burden of disease by identifying people early and intervening early. Simultaneously, in the UK, Crow and his colleagues were working with folks with first episode psychosis, again, trying to identify as early as possible. And then that was followed by a large-scale, literally a trial in Norway. I was involved in training a lot of the clinicians, in fact, all the clinicians in that study. Again, this time working on a first episode psychosis, but educating not just the hospitals and the emergency rooms, but actually schools, colleges, military bases, general social facilities and programs in the community. The joke always was you could ask somebody at the airport in Stavanger, ask the baggage handlers what the early signs of psychosis, and they would often be able to tell you. And so that was, again, just focused on identifying people early, and sure enough, in their study of this, they found that, in fact, they were identifying people significantly earlier, and as you might guess, outcomes were substantially improved, and relapse was particularly avoided by starting early. The same thing was going on in Australia and Melbourne. Same kinds of strategies, which we'll describe in a little while. What also happened in Australia was they followed Falloon's early work and started a second program, also focused on that same part of Melbourne, but this time educating wide sectors of the community on what they call the ultra-high risk stage, same as prodromal or clinical high risk. And again, found that it worked, that basically if you did the right strategies, if you did and put quite a bit of effort into it, the community as a whole could learn how to identify not just early psychosis, but the prodromal phase of things, the early signs of psychosis. Along about that same time, a group headed by Thomas McGlashan, with whom we worked for quite a while, developed an assessment tool called the structured interview for the prodromal syndrome, which has been used extensively and allows programs to, after someone is identified, to essentially meet or not meet a set of criteria that are highly predictive of onset. So that's a little bit of the history. As you probably know, some of you may be members of the Early Intervention of Psychosis Association, which has had many meetings and served as a vehicle to promote and distribute research across the entire globe at this point. And then, as you probably also know, First Episode programs have burgeoned across Canada, Europe, Australia, obviously, and to some degree, more recently, the United States. So I've already alluded to some of the notion of the notions behind this idea of prodromal psychosis and all the symptoms and particularly the kind of cognitive losses that are associated with it. In essence, what happened, and Falloon's experience is a perfect example of this. You use the same strategies to identify early psychosis in trying to identify people who are not yet psychotic or not fully psychotic. In that way, you have to start to think about yourselves a little bit as public health interveners, not just clinicians, because what you're trying to do in the prodromal phase is actually prevent the onset of these disorders. That may seem like high stakes, highly unlikely perhaps, but we'll show you some data that strongly suggests that this works at the level of a community-wide intervention. So think of this a little bit like what we've done in cardiac disease, particularly educating people about good diet, the use of statins, exercise, and what are the vehicles for the dissemination of that information and the vehicles for actually getting people to abide by the recommendations, which they may or may not be inclined to do normally. Those of you who worked in this field probably are aware how difficult that is. So maybe we talk a little bit about the benefits of early detection. I've alluded to them again, but in the subtext here, we're going to be trying to answer the question, why is community education necessary to do this kind of work? And I would say, first of all, our own understanding of this is that if without doing intensive and rather widespread community education, the folks that will be referred will almost systematically be coming in pretty late in the process of having an episode. So the model here is one, in a sense, that's already said, from cancer and heart disease. Lee Hartwell really said this as well as anybody. If you catch cancer at stage 1 or 2, almost everybody lives. Stage 3 or 4, almost everybody dies. The stages 1 and 2 in our work are, stage 1 would be premorbid, let's say schizophrenia. I don't think any of us are pretending to know how to intervene, let alone identify people there. What we're focused on today and in this clinical high-risk population is stage 2. That is, persons have symptoms. They have indications that they're at risk. They're sometimes very intensive indications. Stage 3 and 4, stage 3 would be first episode psychosis, and then 4 is more chronic forms of schizophrenia and other disorders. So we're really focused today primarily on 2, stage 2, if you will, the prodromal phase. It's different than the first episode in one important regard, and that is what you see, especially if you talk to these young people intensively at this early stage, is a little less psychosis and more things like cognitive deficits, depression, social isolation, school failure, difficulties with work, difficulties with social relationships, family relationships, that are, unfortunately for us, a little non-specific, perhaps except with cognitive deficits. With social and environmental triggers acting on a predisposition towards psychosis, the eventual outcome is psychosis, and the eventual outcome past that is the disability. But we're really focused on identifying young people primarily through some of these other phenomena, the ones that Dr. Kornblatt here has identified as CS, CASIS. So this may be carrying coals to Newcastle for folks on this call, but first of all, being psychotic is a really big personal disaster. There's more and more evidence now that the longer it lasts, the more traumatic it becomes. The more there are external forces on the young person that are very, very deleterious, almost because they're having this illness and this onset. Perhaps you're familiar with this, but it's become clear that even in this prodromal phase, there's substantial cognitive losses occurring. Maybe it's more obvious that social functioning is deteriorating to the point where sometimes these young people are acting rather strangely and subject to discrimination and bullying even by their colleagues in high school or in college. But you put the cognitive and social functioning together and think about what's happening to adolescents, this alone is a disaster, because what happens during adolescence is we get smarter and we start to learn how to function outside the home in a social milieu and make friends, and of course, as we all know, that intersects very powerfully with cognitive function, not just in terms of relationships, but also in terms of the school environment and the college environment and the military environment. So all of these things are starting to go seriously wrong before somebody becomes overtly psychotic. That makes it a little bit of a challenge to identify. So my own view is the worst thing that happens in this prodromal and early first episode process is that the person loses insight, and then it becomes very difficult to establish a therapeutic relationship. So unlike, this is where we deviate from cancer and heart disease. Most people having a heart attack or at risk for it, same with cancer, will be very interested in doing something to stave this off. Unfortunately, the more psychotic someone becomes, usually the less interested they are in help and the less they understand what's going on or what's wrong with them. So that's important, because that means that the person who is having the illness and this early phase of onset may be the least likely person to identify that they're having an onset. And so think about it for a moment. You can probably answer the question, well, who would be identifying this kind of phenomenon? And we'll talk quite quickly about that very shortly. So the research has focused using relatively established treatment methodologies for schizophrenia and other psychotic disorders. But what's been different in these early intervention programs is what we're talking about today, is trying to get folks in the community to identify young people having an onset and at risk in this early phase. So we call this indicated prevention. There's something going on with the person that is leading to an indication for intervention, and if you do it early enough, that can lead to prevention. So worldwide, there's been a huge amount of research now going on. Some of it focused at the genetic level. Others, some of the most interesting stuff is on brain imaging, finding even in this early phase significant differences. Neurocognitive work is going on everywhere, really. We have done a fair amount of that. Our own group here is focused also on sensory changes. Naples is the North American prodromal longitudinal study. It's the American. We should all take pride in this because it's turned up a number of important findings about this early phase. Probably one of the most recent, I think one of the most important, is developing a risk calculator. You can literally now, with the right kind of data input, tell a young person in their family what kind of risk they're running for the onset of a psychosis. However, I think there's a widespread agreement across the globe that all of this promise is not going to be realized without community intervention programs that reach out beyond the usual, usual suspects, if you will, involved in the mental health system. In fact, those would be the folks you probably want to get to a little later on. So there are many examples of these programs. Some of you may represent some of them, but as you notice, most of them have been initially at least overseas. As I've mentioned, Norway, a very similar program was developed in Denmark. I worked on that with the folks from Opus. And as you see, Canada also has been historically ahead of us in this regard. So there, in terms of actual clinical trials, there have been many at this point. Interestingly, all of them have used one of three or sometimes two of the three classic kind of interventions, family psychoeducation, cognitive therapy, and biological treatment. By that I mean either drugs or in one case, a large study in Austria, and then a failure of replication actually in Australia of omega-3 fatty acid. So this is not new. The results from all of these trials are really very impressive. About a 66% reduction between the controls who didn't get intervened with and the experimental groups where there was an intervention. And as you may notice in the graph here, the conversion to psychosis rate, those are the green bars, has been dropping over time to some degree as in the control groups as well, such that more recently we kind of expect a 5 to 10% conversion rate routinely for this population when in the same time period you'd expect at least a quarter of these folks to have an episode. So it's about a 66 to I think even higher in some individual studies. So the stakes for doing this right and doing it systematically are very high. In other words, we have in our hands now a mechanism to substantially reduce the number of young people who develop psychotic disorders. But there's a big if in all of this, and that is whether we do it right. Our own experience as a public health experiment here in Portland showed that we reduced the first hospitalizations for psychosis by intervening in the prodromal phase by 34%. And what's interesting and somewhat surprising to us, the effect which occurred in around 2000, late 2000, early 2001, the effect was almost immediate. To the left of the dotted line is the the number of hospitalizations for psychosis per 100,000, and then to the right of the dotted line, that's what happened in the experimental period. So once you start doing this early identification through community education, in many, many instances, the effect is all but immediate. You literally get referrals right after you start doing this. So I'm going to spend just a couple of minutes talking about the early detection and intervention for the prevention of psychosis program. We call it EDIPPP, because I think it illustrates just how profound some of these effects can be, but also how much they depend on community education. So the Robert Wood Johnson Foundation funded this study in 2006. Dr. Elsheim was one of the site directors in the Albuquerque, New Mexico site. We were trying to find a kind of systematically representative sample. We wanted to see if this really would work, essentially replicating the peer program in Portland, but across the country in somewhat more typical places. So we had sites from Portland, Maine, all the way to Sacramento, California, and Oregon, one in Michigan, right outside Detroit, and one in New York, as well as I mentioned, Albuquerque. So the mission was, number one, educate the community on what to look for amongst young people who were either at risk or not at risk. Secondly, kind of build the evidence. In other words, this wasn't a randomized controlled trial. It was a controlled clinical trial, but we wanted to just show that we could do the same level of reduction of conversion risk across relatively ordinary sites across the whole country. We did show and intended to show that this would reduce incidence. It was done more as a public health initiative than a kind of gold standard clinical trial, but we had that clinical trial embedded in it. Ultimately, what we're trying to do is shift the whole paradigm to understand that mental illness, particularly the severe forms, is potentially preventable with methods that, at least in the rest of medicine, are really quite, they're just conventional. They're a very old hat kind of at this point. So just very briefly, what the peer program and these EDIPPP sites did was, as I said, do a lot of outreach and a lot of community education, but also initiate treatment very rapidly by a multidisciplinary team that worked hand in glove across disciplinary lines, following cases very, very carefully and systematically, so nobody drops out, nobody gets lost in the shuffle. We focused heavily on working with the families within a family psychoeducational paradigm, and almost all that work was done in multi-family groups rather than individual families. More recently, we've added CBT-P to this program and some degree of family counseling. A key component at the program level was supported employment and education, and in the peer model, that is enhanced by cognitive assessments to design approaches to supported education and employment that take account of the person's strengths and cognitive disabilities. Less and less emphasis these days on medication management, although at least half of the young people that come in meeting these criteria have a mood disorder. So we often wind up having to treat depression, and in a smaller percentage treating mania or bipolar disorder. Case management is a key part, because if these folks are staying in place in community and they have a lot of difficulties with just ordinary processes of life. And more recently, again, adding peer supports to the team to help guide young people by peers. So that's the program. Here's what happened very briefly between the clinical low risk and clinical high risk group. there was essentially no difference in the rate of onset of psychosis in spite of the fact that the high-risk group was at high risk. So the high-risk group got intervention, the low-risk group did not, and essentially they came out about the same. There was also a smaller subsample of folks in very early first episode psychosis. That's the EDIPPP group, and they had a relapse rate of about 11%. There was, again, no differences between the low-risk and high-risk group for negative events, somewhat higher for the first episode group because many of them were hospitalized. That counted as a negative event. What was very interesting and I think really heartening is whether it was first episode or these clinical high-risk group, their symptoms all wound up to be the same as the low-risk group, which obviously the low-risk group had almost no symptoms, baseline and 24 months, but that 24 months, that's where these folks wound up. They were all but asymptomatic for psychotic symptoms. And even more promising, about 83% or 84% of all of these young people, regardless of their treatment assignment, at baseline, at about 83% in school or working, 84%. However, in the high-risk group and the first episode group, they stayed at 83%. The low-risk group with no intervention dropped over that time. In fact, the clinical high-risk group wound up at 90%. They actually had an increase in their work or school participation. So these were anything but chronic mental patients by the end of this study. They were indistinguishable from their peers in the community. And finally, very large, if you like statistics, there's a very large treatment effect over 10 clinical and functional variables with about a P0007 outcome for the treatment itself. So it really does work. It has very profound effects on short-term outcomes over 2 years. We have a bit of data from Portland suggesting that these things all hold for the up to 10 years later. So that's the overview of the model and the outcomes. I'm going to turn it over now to Rebecca, and she's going to describe how this outreach model works. What I'd leave you with from all of this data, if you will, is the notion that, again, the stakes are very high. That is, in your work, especially if you're working with an organized specialty team, you have the potential of saving young people, and not just a few, but probably more than half, probably closer to 2/3 even, saving them from the travails of a major psychotic mental illness. So, but I'll leave you with this notion. If we don't do the outreach, you won't find them in time. It just doesn't work that well. So let me leave it at that and turn it over to Rebecca James, who's going to describe how this all works.
Thank you, Dr. McFarland. And I just want to take a moment and say hello to some familiar names, Kate Hardy, Ryan Melton, thanks for signing on. And to the 45 participants online now listening up, your power to you. You're doing all the right thing with prioritizing outreach in your area. So thank you for being on this call. The second portion of the training is going to hopefully open up some doors and give you some good nuggets to think about in terms of starting up or expanding the outreach programs that you have now, expanding your education you have now. As Dr. McFarland describes the rationale so well, what I want to describe is oftentimes when folks start up supervision with us or are looking at initiating outreach programs in the area, the questions that come up are, how can we have a full caseload? How could we possibly spend more time on public education? How can we train all of our staff? We're busy as it is. And I think ultimately, by going through the rationale that he describes and what you'll see as we start up programming is that the question really becomes, how can we possibly not do outreach education to change the paradigm of how we're doing the work. So feel free as I go, because this is more nuts and bolts, feel free as I go to use the public chat. I encourage you to do that. Let's make it as live as possible, and we will be saving 15 minutes at the end at a minimum to be answering some questions. So please do use that, and thank you for being involved. So what, who, when, where, and how? That's what we're talking about next. This is a visual that I use that really captures the heart of outreach education and why we do it anyway. So it talks about the cyclical nature between early intervention with the goal of having the earliest possible intervention time, the least amount of time someone is psychotic without treatment, and increasing engagement over time. So there's 3 stages in this that really stand out. The first is the community outreach. And as we described, this is community outreach to the general community, to primary care medical professional, to school professional, people who have hands-on and eyes-on youth and young people every day. So we're broadening the outreach. What we do specifically, and this is very current within what we're doing in the peer program, is we use peers, P-E-E-R, young people, graduates from the program, to really heighten and provide a face and a story to the strength that they've gained in treatment and how they're harnessing their lives in a very different way now because of the treatment they've had in our program. So that's the engagement piece. As we're engaging with, you'll see on the right-hand side of this diagram, as you're engaging with individuals and families, we're creating this flexibility. We're doing the team approach. We're doing high-quality treatment, and ultimately, and people want to stay involved with us as graduates of the program and we develop the peer expertise from within. So that also feeds the community outreach, which leads to earlier referrals as stigma is reduced and people are saying, hey, I'm living proud and living out loud and have some symptoms of psychosis, but am ultimately living a good life, and this is how I've managed it, and this is how I live well. So that's a massive part of what we're doing in the outreach. It's a very hopeful, proactive message that we put out there. Also, just to put a plug out to Kate Hardy and the great work she's doing in developing a larger manual for this, you'll find this in the chapter that Sarah Lynch and I put together for engaging families and individuals in care in her broader manual for First Episode Psychosis program. So good work for you, Kate, in getting that together. So as we describe, outreach is defined as activities that are designed to educate key audiences about the importance of early detection and intervention. The key here is about developing a network of early identifiers, and developing collaborative relationships over time. So this is not a one and done deal. This is about building relationships and maintaining the network. We do that mostly by having speakers, advisories, and bureaus with peers, and by developing relationships with the gatekeepers in our community, equally as much as with the families that have been involved in our program. Our first and foremost goal is to reduce the stigma. This has a broader community impact, and it also helps with early intervention overall. So if there's less stigma overall, if there's more stories of strength, we'll be more likely to use services earlier. Our means of doing that is providing information about the modern concepts of psychotic disorders. So moving beyond the medical model to a model that incorporates more broadly all the aspects of what we talk about in that multidisciplinary, or even better, as we describe it, the transdisciplinary team that works so closely together in many of our programs that you guys are representing here. As we continue on the goals of outreach, it can be as simple as informing audiences about referrals and how to have rapid access to treatment. So if nothing else, if you give people information about signs to notice and how to make a referral, you've done your job. But more specifically, it's about motivation to refer quickly and developing, as I said, these long-term relationships with stakeholders. So as we're doing these interventions and reaching out to our broader community, what we want to make sure is that the knowledge of the signs of early identification and the access to referrals and the network is being built. So this is what we looked at with the peer program when we were doing outreach in our internal community here. You'll notice what I want to highlight on this slide is that tertiary hospitals and ERs, which are typically your primary referral sources, usually at about 80% for most first episode programs or psychosis treatment programs, that in this scenario where we've done active and inclusive and thorough outreach programming that's very purposeful and has clear intent from the beginning, that number has flipped to 20%. Only 20% of our referrals come from tertiary hospitals and ERs. And conversely, our referrals are coming from family members directly or community members, educational professionals, this includes guidance counselors and school professionals, and mental health agencies, which is a broad term that we use to incorporate a lot of more primary service agencies as opposed to acute care communities. So what we've done through our outreach education is flip-flopped and been able to work with people at an earlier point of time than when they're in acute crisis with psychosis. So how do we do this is the next question. Hopefully the rationale is there and you say, yes, I want to do this. I've looked at my referral sources and I want them to come from people who are seeing young people in their more natural settings as opposed to the moment of crisis when things are more progressed. So how do we do that is your next question. And what we answer is it's a very specific process. You start by mapping your community, establishing a steering council, and identifying key audiences. So this is not a happenstance, oh, this person we work well with, we're going to keep work closely with them. This is a broader look at your community specifically. What are your assets and who are the people that you most likely want to hit with intent to be able to refer and develop a relationship for future referrals to the program. So in doing so, we develop these messages for specific audiences. We also specifically train all of the CHR or the coordinated specialty care program staff. The whole staff on the multidisciplinary team are trained in the outreach model, trained in how to deliver the stigma-reducing message, and are specifically energized about it in the same way a coordinator might be on your team. So this is an all hands on deck effort, and that way as clinicians on your team are able to directly advocate with clinicians in the community, as employment specialists or education specialists on your team are able to advocate specifically within the school communities in your area. You use the strengths within the multidisciplinary team to best create the relationships in the community that will be held over time. So that's where you get the most bang for your buck, and you expand it through all the load of the outreach to all the staff. What I'd like to emphasize also with this is there's a secondary effect within the staff. It feels really good to be on the forefront of stigma reduction. It feels really good to be opening up people's minds to look at psychosis in a very different way. It is energizing, and it reduces burnout on a very simple level. Internally within your team, it reduces burnout. So similar to that earlier cyclical slide that I presented, within the team, it has proactive, productive component to it. And the last piece is very simple. To do your best job, you need to evaluate your efforts. So you create a system for feedback as you do within your program to be your best service providers. You develop a system of feedback for your outreach presentations. Did we achieve the goals that we set out to achieve? So the whole staff is involved, and it's a coordinated effort. As I mentioned, the next step is who and where. This is where we talk about key audiences in the community. You start by looking at your existing relationships and connections, those you want to expand upon, and those you want to de-emphasize in your referrals by looking really closely at where your referrals come from. And again, it's not unusual for any early psychosis programs to be looking at who their referrals are coming from and say, wow, most of this is coming from the psychiatric unit or from the emergency room, and starting to question, if it were to look different, if we were to develop some ongoing relationships with the schools in the area, or the primary care clinics in the area, what would that look like and how can we make that happen? That's where we talk about building this from the ground up. So here's a community mapping tool. And what I do, and this is a fun process, what I do when I work with cities and counties and sites who are looking to implement an outreach program in their area is we specifically map out any key stakeholders in the community. That could be elected officials, community activists, so people on the administrative or the advocacy front. You want to be working with them very closely. Supportive community allies and peer services are so major in this, and there's a lot more bubbles that we could add to this diagram here that include all sorts of services that are peer-based and recovery-based for them within your community. Also, as I've mentioned, the academic context and support. So that includes not just high schools, but colleges and universities and middle schools, depending on the age range that you can serve in your area. We also brought in to look at technical schools and school boards. Parents of families that we work with are often on school boards and serve in their communities, so they're often door openers to those areas as well. So often it's not unusual for a school to sometimes initially have reservations about the program coming in and describing what you have to offer. And we've come across that in some school districts, but typically there's always a way around it. So if a principal is not as keen on it as a guidance counselor, you can work with the guidance counselor and have it flow upwards. If a guidance counselor is not too keen on outreach or seeing the value of that, of early psychosis treatment, then there's a parent on the school board that you might be able to work with. So there's always this creative ability to work around that. In medical community context, you'll notice here on this list, we have military health services, public health clinics. As Dr. McFarland described earlier, this is mostly has the feel of a public health initiative. Think back to what he described as the TIP study in Norway. They blanketed the area, the confined area that they were doing outreach with outreach messages. And as you mentioned, the baggage handlers were able to see the early warning signs of psychosis. You want to blanket your community with hopeful messages about people getting better with intervention and openness about living life fully with psychosis and all aspects of that, and how treatment works very much alongside folks. So we want to blanket our community in this, and it's not just the acute psychiatric professionals. Moving on, a key aspect to this, which can often come up, is being aware of who your naysayers are and starting to think creatively around that. As I mentioned within the school district, that if it doesn't work in one direction, try intervening at another level. It's not all that different than CBT practitioners like myself who are working with psychosis, who say if we can't intervene at this, at this thought level, then we're going to intervene at the behavior level. There's different points to drop in, and that's the excitement and the nuanced effect of doing outreach education. And the key is doing it within this coordinated plan to specifically flip-flop those numbers from 80% acute late-stage psychiatric care to 80% from the community, family, school providers, and young people themselves. So within that, we look at what are our priorities. Middle schools and high schools, again, these are the different areas you can drop in terms of your interventions. Healthcare professionals, UCPC, primary care providers, nurses, social workers, colleges and universities. We've run a very successful campaign in our local university here in Portland, where the week that freshmen come into college, that week before they come into college, when they're doing all sorts of get-to-know-you events, we have been able to do a stigma-reducing mental health awareness activity with them, that the RAs in the dorms become more aware, and young people become more aware of how to look for signs if somebody's struggling. And then, of course, broadening your mind. So are these people that you think of going out to do outreach to? Do you think generally about law enforcement? Do you think about VA clinics? Do you think about businesses in the area that are hiring young people? Do you think about clergy? How about athletic teams and coaches? Have these crossed your mind as creative ways to have a stigma reduction message out there? And of course, using social media as a platform. The young people that we're working with are using social media as a platform as they start to own their recovery and feel stronger with what they've been through and take ownership of that. And we as programs as well alongside them and like highlighting those voices in those stories as we go. Social media has immense power to be able to do that. So as you see, as we reach out to all these areas, we reached out a little too far. As we reached out to all these areas, as I've just described, we get referrals back from them in a much more balanced way. See how this looks like a network that's holding psychosis and holding the interventions and referrals in check. It's not just one arm that's doing most of the referrals or one leg that's doing most of the referrals. It's coming from a network of providers, and community members and employers and pediatricians and teachers who are all holding this together as a community. That's how outreach, when done well, is about a social catalyst for change and about the stigma reducing in a very positive and proactive way. So our early detection intervention program, of which many of you are representing, the key is, as we're developing the first stage outreach target audiences, is mapping out your community. Who are the health professionals, who are the school and college professionals, and who are the social service agency providers, and then listing it out here. As part of that, we can work closely to develop priorities within that, and for action steps, 1 month to the next, to be able to hit targets to make sure you're continuing to both start the outreach effort, maintain the outreach effort over time, and maintain the relationships over time. They're very live and vital. What we know also with outreach is that when you put a massive effort out, like they did in Norway with the TIPS project, when you blanket a community with anti-stigma messages and blanket a community with how to make a referral, how to recognize the signs, we see very quickly outreach works. When that's taken away, when for whatever reason outreach stops or there's a break in that, referrals do start to fall off pretty rapidly and pretty quickly. We saw that in Portland when we had a temporary loss of funding and we were unable to start. We had to rebuild. We had to get creative. And that was for a period of, I want to say 3 years that we had a stop in funding. But again, putting emphasis on what the power of outreach is in the end is that because we had such a powerful network built from all the earlier years of outreach at all those levels, we had parents and providers writing op-ed letters to local newspapers. We had gatekeepers that were political members that were saying this needs to get refunded. We had a lot of people on different levels saying this is not okay, this program needs to restart, and we found a way to restart. So it's our sense that it's because due to our, not just our good treatment that we have, but to the outreach that we did and have maintained over time. A living, breathing process. So as part of this, we look at cultural considerations. So outreach is going to look very different on a, well, different in the same, but on like an urban setting as it is in a rural setting. There's some, you know, when you look, there's some aspects that are universal, but are also very specific to each community. And that, again, is the fun and the creative process of this community mapping that we do with outreach and different agencies as part of this identified program. So we can really map forward and predict the considerations that are unique to each area. So we look at what are your outreach efforts to date, and we include very closely the introduction of a steering council. And this is something that, as part of the actually delivering the messages and mapping out your community, figure out what you're saying and when and how you're maintaining your relationships, The steering council is a set-aside, very explicitly chosen group of people who will be your advocates when things get difficult, your door openers, your sort of potentially gatekeepers, your people who will be your cheerleaders in areas that you need to and would like to expand your referral base and your message of stigma reduction. So this can be a meeting of 5 to 8 people, 12 to 15 people, but clearly like a group of people who are actively supporting you and who say, get me your brochures, get me your website, I want to get it to all of my medical offices in the area. Or parents who say, I need to get this out to other parents that I know, I want to make sure this is in all the schools. So it's similar to the outreach map. It involves people from all aspects who are really your cheerleaders from within. And we find in our steering council and advisory committees that we've done in Portland, the most excited people about this project are those who have personal experience, and that's where our peers leading the steering council and speaker advisory groups. It gives it more power. So our messages are clearly, as I've mentioned, about reducing discrimination, reducing stigma, providing, as I said, important information about modern concepts of psychotic disorders. We emphasize most specifically how psychosis, as I'm sure many of you do in the work, but this is a more broadly a question of psychosis happening on a spectrum and how it's related to stress and isolation and family support all improves the symptoms, not unlike mood disorder symptoms. So we do a lot of normalizing and understanding as opposed to othering and isolating, which is so typical in psychotic disorders. An excellent message and exciting message to put out there to the community at large. And talking about this as stages of mental illness and recognizing the earliest possible warning signs and how to not delay as opposed to take a wait and see approach. So specifically educating about the early warning signs of psychosis. Again, not unlike we educate about the early warning signs of mood disorders and when to worry and when what are normal, healthy transitions. We provide information on how to make a referral, and we also make ourselves consultants in the community. So we say our number is passed out very broadly. We try to have a lot of traffic on our website. So we want to be able to, if you don't know what's going on, just call us. You have a very low barrier access to your program to encourage people to call you earlier as opposed to later in the assessment. So that collaboration comes all together when we provide this. So we have talked, sorry, excuse me for 1 minute. I just wanted to make sure I have enough time to go through these last couple slides so we have time for questions. So we've mentioned again, who does outreach? All of staff does outreach. And it's about being adaptive and flexible, and that's in the same way that we do so well within our programs. It's doing it broadly. So it's sort of speaking and saying what we're doing internally in our programs, but now more broadly in the community. And we do a lot of proactive outreach. So especially in the beginning, you want to be able to be targeted about who you provide outreach to and where you want your referrals to come from so that you can reduce stigma as much as possible. And later on, you'll notice you'll get a lot more requests for presenters and information, so that would be a reactive type of outreach. So both are good for developing collaborative relationships over time. And just remembering who are your priorities, what is your general outreach plan, and are we sticking with that? Okay, so we see some questions coming in. Is that? Oh, I missed one. Okay, thank you. Oh, thank you. So thank you, Dr. McFarland. I missed about how to deliver the message, what are the mechanisms to deliver the message, and what we like to do as much as possible is in-person presentations. So these are often with a peer within our team doing these presentations alongside us. So locally in the Portland area, one of the things we do is, and anyone can attend this, but once a month we have our workshop, which is an hour-and-a-half classroom-style format where we provide the basic information about spectrum of psychosis and stress and stress diathesis model, and what is hallucination, what is a delusion, and what are the earliest signs of psychosis. So we provide all that information and what family members and friends can do to help. It's an hour-and-a-half presentation. It's led jointly with a peer who's talking about her personal experiences and with some of the clinical staff on the team, and anyone can come. So referrers, people who are making referrals, family members, friends of family members, teachers, anyone and everyone can come to that. It's a low barrier, and it happens every month, so they know where to go. People sometimes come more than once. Sometimes when they're in the program, they come back and go to it again because it's a very hopeful message. We also use webinars like we're doing today, so it's another very easy way to get information out there. We spend a lot of initiative making videos and developing our website, and are working on social networking. So as part of our program, in the final stage of our program, a lot of young people are developing sort of their own YouTube-style videos of where they describe what their early warning signs are and what their symptoms are, and they share that more broadly. So we can use that as well. We're developing a library of peer stories of strength in terms of psychosis. So storytelling does a lot more, as we know, carries more power than reading through numbers or going through a PowerPoint presentation. Storytelling is where it's at. Okay, so we want, in essence, we emphasize that materials are as important as messages, and stories are the most powerful form of material. And what we wanted to do, to spend the last 12 or so minutes of our presentation, we wanted to make sure that we could open this up for questions and discussion. So if you have anything in particular from your site that you would like to jump in on and have some input or consultation on, please let us know. And I think Dr. McFarland wanted to emphasize our manual that we've recently done for SAMHSAT, which is also available for download for you under the community sign. So you see this, thank you for pulling it up here. So this is the Educating Communities to Identify and Engage Youth in the Early Phases of an Initial Psychosis. This is a full manual for specialty programs. This is chock full of information that we've described today and specifics of how to do this in your area. So this is available, this is the technical assistance manual, and it's available for your download. If you have any further questions, you can contact us about that as well. And Dr. McFarland, did you want to add anything about that manual?
Well, yes, in particular the fact that it's public domain. So everything we said today is reflected in the manual, but what the manual brings to you is a lot of much more specific information. For instance, I think one of the tips that we've evolved has to do with, in spite of the fact that we're talking about all the members of the team be involved in outreach, we've also found that very often certain audiences are reached much more easily by specific disciplines, and by that I'm particularly meaning physicians. It's extremely important to reach pediatricians, family physicians, and adolescent medicine internists in your community, because they are seeing these young people at an often very early stage, and they usually don't identify it, and they usually don't know what to do with these kids, in essence. So they tend not to do anything. In most communities in the United States now, there's such a dearth of child psychiatrists and child psychological services available that many pediatricians see difficulties in one of their patients, and they kind of throw up their hands, say, well, there's nothing I can do about this, so I'll kind of forget about it. So our experience has been that it's extremely difficult as in the process of outreach and community education to reach these same physicians. And the people who can do it usually are the psychiatrist on the team or the nurse practitioner. And so that's one specific kind of discipline-specific aspect and tip. Same thing goes for nurses, and to some degree, many of the outreach efforts in our consulting and training other sites have been through, for instance, social workers who are relatively blocked in trying to access schools, high schools in particular, found that their colleagues on the social work staff at the school were quite interested in having them come. So reaching out on a discipline-specific basis is often successful when other things might not be. I could tell you just one story that I think illustrates both the promises and some degree the problems that are associated with this kind of work. One of our sites, and I guess we'll have to be relatively specific about it because it's unique, and that is New York City. So one of our sites was serving an eastern part of one county of New York City and the western part of a suburban county in Long Island. And I think nothing illustrates it more exactly than the fact that when the staff reached out to the school district in the suburban county, they were welcomed with open arms. Immediately, there was a recognition on the part of the senior level of the school district that this could be invaluable to their students and to their faculty and to the parents in the community. And so they were incredibly helpful, very cooperative. They arranged a number of different events for particularly the senior guidance and professional staff in the community, high schools and junior highs for that matter. At the same time, the staff from the program tried to reach out to junior high and senior high schools in New York City and were blocked, specifically told they would not be allowed to make any presentations to any staff under any circumstances. This was a citywide policy. I'm pretty sure it was driven by the fact that in New York, there would be a lot of people trying to essentially use presentations to high schools as a commercial opportunity, everything from Coca-Cola to maybe even cocaine or something. So this is where the staff became rather creative and also had a little bit of luck. The program director had a doctorate in psychology, which he received recently and relatively mid-career. His earlier career had been as a high school teacher in that same county. So he's just started calling his friends who still were working in that high school, made presentations, found that as in the other county, they were very welcome in the schools, and the schools quickly recognized this was a major service, was going to save some of their, some of their students from a very serious illness. And then all of a sudden, the program staff starts getting requests to make these same presentations at other schools throughout the district. And so in the end, the two districts wound up with about the same level of community outreach. But the mechanism for the two counties were completely different. So in almost every instance, there are going to be peculiarities of your territory that you simply have to address. Hopefully, in the planning process and through the steering committee, you'll identify the problems and also the real opportunities that you'll have that are specific to your own community. I think the other thing that I would mention is that we've now overseen, I think, 18 different programs being developed. And in every one of them, it's been just different. And in particular, what's different are local programs that reach out to young people in a variety of ways, and it can be sponsored by local fraternity organizations, religious groups, the military. It varies site to site. One of our largest programs is in San Diego, and there they've reached out to, on one side, the community college, San Diego State University, and on the other side, the big naval base in San Diego. And in both of those instances, they had to go about it completely differently and think it through, try a few things, and also engage leadership in those various organizations. We had, I should say, a naval air station in our own catchment area here in Maine, and we were surprised. We asked the health service at the Naval Air Station whether they'd be interested in a presentation about what we were doing and interested in making referrals. My thought was they probably wouldn't be. The Navy has its own health system, and then there's the Veterans Administration. But somewhat to our surprise, they were very anxious to work with us because many of the young ensigns at the Naval Air Station, unfortunately, for better or worse, were ashamed and fearful of describing their onset symptoms to their own, superiors at the Naval Air Station. So they were, when they found out that they could come to Portland and receive care here, most of them were happy to do that. And interestingly, the Naval Air Station was quite cooperative in doing that. So, but you never know what's going to happen actually until you try. Again, Rebecca mentioned this notion of a steering council. That group can be very, very helpful. I think it's indispensable in terms of plotting out a good intervention plan, and then also revising it as you go forward over time as needs present themselves. So I think it's about time we open this up for questions. I think we'd both be interested in any of your descriptions of either things that have gone well in your efforts to educate your own communities, or problem issues that as you can hear from what I just said, this doesn't always go straight ahead, and it's not always easy. Even in spite of that, I think we both have tried to communicate that it's essential to finding young people at an early enough stage that they can be prevented. So why don't we leave it at that and open it up to the community?
Thanks, Bill.
Steve, you could lead off. You had any thoughts?
I do. Thank you, Bill, and thank you, Rebecca, for really a wonderful presentation. And as they suggested, we have about 15 minutes left to take additional questions and comments, and we have several we're going to be touching on. Before we do, I just want to highlight a couple of things, and because I know some people are going to need to be heading off over the course of the time before we fully stop. So just a couple things to share. One is that we are really pleased to suggest that you all save a date. October 2nd, 2019 is going to be hopefully our second National Advancing Early Psychosis Care U.S. Conference. That's going to be sponsored by NIMH, SAMHSA, PEPNET, and the American Psychiatric Association as a pre-conference to the IPS Mental Health Conference sponsored by the American Psychiatric Association in New York City. So I just want to be sure that people are aware that, we had a wonderful meeting in Boston last October as a first meeting, and at this point we're planning a second one on October 2nd, so save the date and would love to see you if that works for you to make it. The other thing is, Rebecca, I know, referenced the chapter that she and Sarah had worked on in the book that Kate Hardy was involved in, and Kate added a link to reference that book as well. So that's on there as well. And then we have several other questions to start with. And so why don't we go ahead and start taking a look at them. And then as you have other questions, please post them and we'll do our best to start addressing them as well. So the first one for Bill and for Rebecca from Sunny Cheng really speaks to the question of, since prodromal symptoms are not specific, do you recommend using the SIPs? And if so, since it's generally implemented by healthcare professionals, how do we make it widely used and available as a main screening tool within the community?
Well, I have a rather strong opinion about that. I don't think it can be used outside a specialty team, or at least a very, very highly trained group of clinicians. So we don't recommend it. I think the developers and the current authorities on the SIPs would agree with us on that. However, I would hasten to add that there are one or two short versions of the SIPs, if you will, that survey for kind of a once-over lightly version of pre-psychotic symptoms and other associated symptoms and signs of early psychosis. One of them was developed by the group at UCSF, and we have had one instance. I should tell you about this. It doesn't have much to do with outreach. A major mental health center in the West decided to institute a routine administration of the short form to every young person who came into their clinic and was referred for anything, prodromal or psychotic symptoms notwithstanding. And their referral rate for to the SIPS assessment and the identification of young people at risk or early psychosis went up by 2 or 3-fold. So it's an important question. I think the field is still wrestling with what's the best approach. I think most of us feel that routine screening in, for instance, high schools or college populations is still too fraught with difficulties and uncertainties to be done systematically. I have a feeling that that might change at some point. If you follow the course of mental health first aid and its distribution and dissemination in high schools, there's quite a bit of good experience, I think, that suggests that young people should be assessed at some level for mental health issues. As we often say in our outreach and educational presentation to schools, a psychotic disorder is the worst thing that happens to the most young people. That's just a statistical truth. So other things, obviously suicide, are worse, but they're extremely rare. This is going to affect about 2 to 3% of high school and college and young persons in that age range. So I don't think we've got the best answer for this yet. I hope we have groups trying out sort of small versions of community screening, or at least population-wide screening through schools and colleges. I think some of you may be aware, but there's more and more data that suggests that young people in this adolescent and young adult population are reporting kind of catastrophic levels of anxiety and depression that are sort of unprecedented. Most of the time when we do these presentations in high schools, the more experienced teachers and guidance counselors say, yeah, there's something about this last cohort of young people from the last, I'd say up to 10 years, that are just substantially more affected by general mental health symptoms, and of course that puts them at a higher risk in general for psychotic symptoms. So kind of a long answer to a very good but a tough question.
Thank you. Appreciate it. So we have several questions also coming up really about access to resources. So let's just touch on a number of them. One of them from Jen Vose is looking at, I think, Bill, you referenced a training manual for multifamily group. And she was wondering where to best access that. And then there are other questions about whether or not either of you know of public domain resources that can be good handouts for youth or families that sort of explain the idea of the continuum of clinical high risk and early psychosis in what is sort of family and youth appropriate kind of language. And then also any resources for youth who might be experiencing a first episode of psychosis, who might be having paranoid types of features as well, as coming from Laura Dickerson.
Sure. Well, the multifamily group manual, that's easy. It's published as a book called Multifamily Groups in the Treatment of Severe Psychiatric Disorders, Guilford Press, 2002. And I think you can get it, I know you can get it now in paperback. So it's an old book, actually, at this point, but that's it. Rebecca, what about the, well, I think the other thing that if you become a client of the Peer Training Institute, we provide a lot of materials for family workshops and information and sheets of various formats that are available through our institute and that then can be adapted with logos and so on for a particular program and agency. As for, I don't know, what would you say about resources for, in a sense, for the general public?
Well, I mean, what I would say is the spirit of what we do and the reason why we have these monthly calls and webinars is about information sharing among programs. So, for example, the peer program, we have our own website, and some of the material you'll find on there for some of our videos, as well as the handouts that we use, how to look for early warning signs. And we hand those out broadly. You'll see the language on that is very inclusive as opposed to exclusive. What we've really lived by and live and breathe is very specifically having broad characteristics and broad warning signs to look for, and following that up with prodromal questionnaires that can be done at intakes or for upon referring in. But for general broad community and information is to cast a wide net and to make ourselves available for consultation. But so that's within the peer program website. But most coordinated specialty care programs and early psychosis programs are developing materials internally and are available on websites that you find around. So I encourage anyone who's in on the call to share their own websites and their own favorites. You're welcome to put them up on the public chat. And that's why we're doing all of this, is to share information on public domain as well.
Yeah, if you're interested, we commissioned a video that tells the story, if you will, of families and their experience as part of the Robert Wood Johnson Foundation's EDIPPP study. And those are available on the Robert Wood Johnson Foundation site, if you look up for the EDIPPP site on the RWJF site. And I think you'll find some of those, well, one of them is spectacular. It's about the course of treatment and early identification and subsequent to treatment of a young woman who was identified by the health service at our local university.
Yeah, and just to add a quick story about that, if you look on our on the Peer website, you'll see we have a video posted of a young woman speaking. This was years ago now. Preventing the onset of severe psychosis, I believe is the title of it. And the young woman who presents in that, her name is Tiffany, and this was a video that was taken maybe 15 years ago, quite a while ago, but we saved it, and for one reason. Tiffany has been in touch with us through many years and has been involved in our Speakers Bureau, and this is the highlight of how if you maintain relationships over time, that's what buoys your program through rough moments and through rough patches. And earlier this year, Tiffany presented at a panel that we had of young people living with early warning signs of psychosis and how the treatment that they sought. And she was able to say, I am now 15 years out. from my initial episode, during which I interfaced with the peer program. And my experiences with that program and in understanding my early symptoms and what I needed to take care of myself and getting treatment early and the importance of that led me to go back to school and get my degree as a nurse practitioner. She completed her NP program, and she, in her first years of practice as a psychiatric NP, she went up to the Native American reservation in sort of northwestern Maine, the part of Maine that has no paved roads. It's all mostly dirt roads, and access to mental health treatment is extremely limited. She started her practice there, and now she's practicing as working with early psychosis with young people. So that's how it comes year-round. That's 15 years later, but those are the kind of cheerleaders and comrades that you build when you do quality outreach education and you do quality programming over time. That's what this is all about.
Thanks, Rebecca. And as someone who's seen Tiffany's growth from afar, it really has been wonderful to see her leadership and her support for other young people as well. So it's a really wonderful story. A couple of links. One I added just now, and Bill, as you were referencing, there was a point with the Robert Wood Johnson Foundation EDIPPP study where many of the materials were posted on the NASHBID website in one particular area. So I put that information on there. So it has background materials. It has some of the videos as well. It's a pretty easily accessible place for people to pull down that information. And as much as it's a number of years old based on the study itself, it still is a really valuable site. And then we see the other link to the peer training site and the peer model as well. And then Michael Garrett, raised a really valuable point for all of us to consider, and I wonder, Bill or Rebecca, if you would want to comment on it. Michael is really referencing the value in partnering with local law enforcement in San Diego, and references their presentations that are happening several times a year within San Diego, and it's really made a big difference in terms of collaboration and appropriate referrals. Would either of you want to make a comment about that as well?
Oh, sure. We worked very early with our local police department when the CITI initiative was starting nationally to train local police forces in crisis intervention, especially in crisis intervention relating to mental disorders and mental health crises. And so we did, some education with them, which led to, again, appropriate referrals. But it had a second effect. This amplifies Rebecca's point about networks, because then they ask us to annually do education for all of their new recruits into the CITI program. And I don't know if that's still happening. Is it still happening?
It is, yeah.
Yeah, so that was 15 years ago. So the program now is the major source of training for our local crisis unit of the police force. And of course, that just works well for everybody, the whole community. It works well for the staff of the program, for the police. They have a referral, a ready source of referral availability, which they need, et cetera, et cetera. You can imagine how well that works. So yes, it's one of the points on that diagram, police officers, correctional. Right. The other one that you must pay attention to, if you have one, is the local, quote, reform school, the correctional facility for adolescents. It is distressing when you go in these places to see how many of these young people who ostensibly are, burgeoning criminals are actually having the onset of an early psychosis and need help fast and do really, really well when they get it. So, yeah, that's it.
Thank you, Bill. Yeah, that's a great reminder as well. So before we all log off, I want to thank Rebecca and Bill for a wonderful presentation and wonderful resources. I want to send you back to look at their outreach guidance manual again, which is linked as here. And before you go, please take the survey so that we can continue to improve these webinars and presentations. You can see the link there as well.